Thank you.
We'll move on now to Dr. Gandhi, who has returned from her trip to the CFAR directors meeting. Dr. Gandhi, as you know already and have heard, is a professor of medicine at UCSF, runs the AIDS program there, and has made contributions across the board with HIV, and has played a major role in our response to coronaviruses as well. Today, she's going to talk to us and give us some state-of-the-art antiretroviral cases to ponder. So, Monica.
Thank you. First slide, please. And this is going to be lots of questions for us all. So this will be please get ready to do a lot of voting because I put in a lot of audience response questions, because many of these slides that hopefully we're putting up right now are, oh, how do I share my own slides? Then you're going to, every time I have a question, well, I see. Okay, we can do that. You'll, every time I have a question, then we'll go back to the other ones. Okay, so yes, I'm going to, there'll be lots of questions because there's so many things that aren't clear in HIV medicine. So I hope that we'll all be weighing in. Okay, so to talk about a couple of cases, oh, I have no disclosures. This is a 52-year-old man who was diagnosed with HIV 30 years ago. He was on EZT3TC, then EZT3TC nevirapine, then TDF-FTC efavirenz, first as separated and then a single pill combination. He had off and on problems with adherence and viral load detectability, and he emerged a K65R, M184V, K103N, and a D67N mutation. He was switched to BID raltegravir, etravirine, darunavir, ritonavir, the trio regimen in 2008, and then simplified to dolutegravir, doravirine, darunavir, Cobi once daily in 2018. He still has variable adherence, no new mutations from above, and he wants a change from 3 pills a day. He said that it's just too much. He's housed, he's food secure, and he wants to simplify. So what is the regimen that you would choose for this patient? Would you choose BIC-TAF-FTC? Would you choose darunavir, Cobi, dolutegravir? Would you choose the 1-pill dolutegravir, rilpivirine? Would you choose cabotegravir, rilpivirine intramuscular? Or would you try the 1-pill darunavir, Cobi, TAF, or FTC? Please vote. Okay. So it looks like a lot of you chose the darunavir, Cobi, dolutegravir, along with BIC-TAF-FTC. Those were tied together. So great. So let's go over some of that data then. So the patient was started by your colleague on BIC-TAF-FTC. Now remember, this patient does have a K65R, an M184V, a K67N, but your colleague said, oh, you can't get INSTI mutations on bictegravir. So is that true? And in rare cases, what are we seeing as an emerging signature mutation for bictegravir? Is it N155H, E92Q, the Q148H, the L74I, or the R263K? Please vote. So Q148, which is a very important mutation actually for dolutegravir, is in this case not what seems to be emerging, it's more the R263K, but let's talk about that data. So, you know, really bictegravir does have a high genetic barrier to resistance, and where we have seen the emergence of resistance would be in a patient like this, would be a patient who has underlying K65R, other mutations that are really making the TAF-FTC barely able to work, and we just have BIC alone, and then we have the setting of poor adherence. So what did we know until recently? The switch studies, the naive studies did not emerge bictegravir resistance. So high genetic barrier, at least in passaging it through in vitro, we saw emergence of different mutations, but it's really in the clinical studies when you have case reports that can tell you what's coming out really in clinical failures that gives you a hint of what's most likely to cause bictegravir resistance. There was one patient that, here's a case report, who had a Q148H and a G140S that was transmitted at baseline and wasn't detected in one of the studies, and did, however, retain virologic suppression for a prolonged period of time, and likely going with the Q148 and the G140S. So it doesn't look like that's going to make bictegravir fail. But what have we seen in case reports? Well, there's really been just 4 case reports. They're coming out very recently. There was one that was shown at HIV Glasgow, not yet published, who was a patient in Germany who had a high viral loaded diagnosis, a low CD4 count, developed, unfortunately, PML, and was put on Bic/TAF FTC, but did have poor adherence, and after a while developed an M184V and continued on the medication even with poor adherence, and ultimately developed an R263K and failed bictegravir. There was a second patient who, this is an antiviral research, same sort of story actually. Bic/TAF FTC started with a high viral load. After 2 months, poor adherence again, developed an M184V, continued unfortunately on the medication, and then developed an R263K and failed. We had a patient at our clinic, Ward 86, who had the exact same story, poor adherence, first of all did an M184V, then an R263K with high virologic failure, and then finally a case report in OFID, that's a 51-year-old man, cryptococcal meningitis, poor adherence again, first developed M184V and then R263K. So I would not start a patient who has a K65R, an M184V and other TAMs on bictegravir TAF FTC with a known history of poor adherence. So let's think about other options. So the patient was quickly switched off Bic/TAF FTC when we realized these failures can occur, and onto dolutegravir rilpivirine. And he called 2 weeks later and he said, well, he likes it, but he's taking out his usual adherence pattern of 1 to 2 missed doses a week. So what do you think? Would you continue this? Well, the SWORD trials excluded participants with prior virologic failure or any mutations, but do you use dolutegravir rilpivirine with NRT mutations? Well, no, I adhere to the inclusion criteria. Yes, NRTA mutations will not affect this regimen. Yes, but I assess adherence first. I have not, but I will think about it. Please vote. So great. So this has gotten people thinking, because in a way, right, NRTI mutations are really irrelevant to using dolutegravir and rilpivirine. They, neither one are an NRTI. And I think it can be used, but the question is what many of you also said, I assess adherence first, because sometimes NRTI mutations are a marker of poor adherence, and dolutegravir rilpivirine, at least rilpivirine part of it, does not have a high genetic barrier to resistance. So in this case, you did think about adherence. It made you nervous to have the patient on a rilpivirine regimen, and you decided to switch him. And this is the data that shows that really the SWORD 1 and 2 trials that showed us that rilpivirine dolutegravir worked as a switch regimen. Remember, this was a switch strategy when patients already had virologic suppression. It was adults on stable ART. They didn't have any previous virologic failure. They actually couldn't have previous mutations of any sort. And they had to be virologically suppressed for 6 months prior to switch, and then switched. And of course, this is a highly successful regimen, but this was in the context of no mutations and likely high adherence. So you're increasingly using this with patients with NRTI or PI or even K103N mutations if they're now adherent and they've changed what could have happened that led to those mutations. But this patient does report problems with adherence. And so you do switch to darunavir, Cobi, TAF, FDC single pill combination. Now, the darunavir, Cobi, TAF, FDC combination was approved on 2018, and it is a regimen that is for either ART naives or virologically suppressed. At least that's how it was studied. But it does have, darunavir has the highest genetic barrier to resistance of the ARVs. It is a first, really, this is the first PI-based single pill combination. It has the right amount of TAF in it, 10 milligrams, not 25 milligrams. And the EMERALD study really showed us that we could use it in this context. So let's talk about the EMERALD study. The EMERALD study was a study that again, not exactly this patient, because these participants were virologically suppressed on a boosted PI regimen, but they were randomized to staying on that boosted PI regimen or going on to darunavir, Cobi, and the inclusion criteria is that they had to be stable and their viral loads were essentially suppressed up till then, kind of like our patient, though he has more problems with adherence. That was probably reported in the study. But importantly, the question of underlying NRTI resistance was raised, because that's the patient that we have in front of us. And so virologic suppression was maintained out to 96-week data now that we have at 91%. And it looked good out to 96 weeks. But what about the underlying NRTI mutations? Well, anyone who failed on the single pill combination did not develop, as we've come to expect, darunavir-associated mutations, though one failed with an M184V. But in those who had prior virologic failure, and GenoArchive data at least, 38% had emtricitabine RAMs, mostly the M184V mutation, 4% had a K65R, and 21% had thymidine analog mutations. And despite that, despite at least these proviral mutations, all the patients, participants in this trial maintained virologic suppression. So that was one possibility, though this is quite a bit of resistance, and many of you voted for dolutegravir and a boosted darunavir regimen. So my question is, was there ever a trial performed to look at this combination of dolutegravir plus boosted darunavir as two-drug therapy? No, but as we talked about here, it made sense this would work. Yes, it's called the DUO trial. Yes, it's called the Foxtrot study. Yes, the Dualist study, or yes, the Doppelganger study. Please vote. And essentially, most of us had no, but it makes sense this would work, as many of you had voted for. But actually, there is a trial called the Dualist study. So the Dualist study was published. The Dualist study was published last year in OFID. And this was essentially that very question. Someone like our patient who has underlying resistance to NRTIs and who ended up getting switched to dolutegravir and boosted darunavir after virologic suppression, because remember, he was tired of taking multiple pills. So it was a phase 2B study. They had to be virologically suppressed for 6 months and no darunavir or entity mutations, but that would fit the criteria for this patient. And actually it had in low enrollment. So there's 130 in each arm, but the Dualist regimen, the darunavir boosted with dolutegravir looked very good. Same as keeping on 3-drug regimen. And actually the lipids were better with the tenofovir regimen. So you tried to put the patient on what many of us said, dolutegravir and darunavir Cobi, but he points out that doesn't actually feel that different from dolutegravir, darunavir, Cobi, doravirine, and he wants one pill once a day. So you go ahead and you try it. You try dolutegravir, rilpivirine, but you counsel him on the importance of adherence. So he does fine for 2 months. And then by the 3rd month, he reports that he really was doing more of a off and on pattern of adherence. And unfortunately, he has emerged both in an E138K, which is a rilpivirine associated mutation, and 2 INSTI mutations, a Q148H and an N155. So he now has resistance to rilpivirine, INSTIs, and NRTIs. So our experiment was not successful. So what regimen would you use next? Would you use fostemsavir plus darunavir-cobi plus doravirine? Doravirine plus darunavir-cobi, he has an E138K. Fostemsavir plus darunavir-cobi, fostemsavir plus doravirine, or fostemsavir plus ibalizumab. Okay, so some of you actually will give him doravirine, darunavir-cobi with the ultimate promise that he would, really has to stay on this because we have developed a lot of resistance, and the majority said fostemsavir, darunavir-cobi, doravirine weren't going to give him a 2-drug regimen. So I agree with that actually, but let's talk about fostemsavir for a minute. So really, fostemsavir was approved on July 2nd, 2020. For heavily treatment experienced patients. And it was this type of patient that had still remaining ARV classes. In this case, the patient should have 2, doravirine and darunavir-cobi, because no PI resistance, and it was just at E138K, but wanted to add on to that failing regimen a new agent. This is our only attachment inhibitor that we have. And essentially there was an advantage over adding fostemsavir 600 BID to the failing regimen with the optimized background regimen in terms of maintenance of virologic suppression. Or virologic reduction. So you are still curious though, just want to make sure and confirm that doravirine susceptibility is maintained in the setting of the E138K. So you actually do a phenotype and confirm that isn't actually a doravirine associated mutation, and that's shown here. And he really, I think the fostemsavir BID would be the safest thing to do. And certainly if there is no possibility of ever missing a drug again, we could try doravirine, darunavir-cobi, like some of you said. So we'll leave that hanging. Okay, so the next question to you is, have you started a patient on injectables yet? So yes, no, still figuring it out, or waiting for even longer acting ARTs. Because this is an exciting time too. So no, not yet 46%, but 21% of you have, and a few are actually waiting for some of the agents that Dr. Benson talked about. So let's talk about a case that a couple of cases here at Ward 86, these are real patients. So 49-year-old man, history of HIV since 2003. And he was started on efavirenz TDF-FTC at the time, but he developed his elevated viral load and had a K103N in 2008. So that was when raltegravir came out, and he was switched to raltegravir TDF-FTC. And then to the single pill combination of elbaptegravir-cobi TDF-FTC in 2012, and then dolutegravir bacavir 3TC when it became available as a single pill in 2014. He has been virologically suppressed since, but he says, now I read about these injectables, please give me the shots, I want them, but I don't want them every 4 weeks. I'm really busy, and I want to come in as little as I can to get the injections. So no other past medical history, no other meds, and he's married, and his husband is not on PrEP. So would you give this patient injectable cabotegravir? Well, no, because he has a history of a K103N. Yes, but I want to do it every 4 weeks. Number 3, yes, but every 8 weeks. 4, yes, every 4 weeks for a while, then I'll be comfortable switching. Or 5, I have great bedside manner and say how hard it is to take one pill once a day for Pete's sake. Okay, so no, 18% has a history of K103. Yes, every 4 weeks. Some, because he's asked, will do 8 weeks. And then maybe first try 4 weeks, then 8 weeks. That's the majority opinion. Or the other said, no, let's just keep it our oral. Okay, so, what is happening with why do people want injectable ARVs so much? I mean, there's no doubt. Obviously, the oral antiretroviral therapy has been revolutionary, but it is hard to link and stay in care. There have been problems with adherence in multiple communities: youth, marginal housing, mental illness, cognitive impairment, food insecurity, substance use, adverse effects. There's just pill fatigue and the stigma of the daily pill and a reminder that I have HIV. And that really, for this patient, was his desire to switch to an injectable agent. So multiple reasons why people would want to be on injectables. And I really think that before we got them, we were thinking of injectables for highly adherent as one category, and then as poorly adherent as another, though we don't have a lot of data in how to use the injectables in the latter population. And barriers for highly adherent may be circumvented by quick in and out shot clinics or pharmacies, mobile vans, maybe self-administration of the shots at home, and certainly having oral bridges at home. So let's remind ourselves of the inclusion criteria of the pivotal studies for long-acting CAB rilpivirine, to remind ourselves if this is a patient that we feel comfortable trying to go for 8 weeks. Now, remember, the ECLAIR study showed us that it can't be given every 12 weeks. In fact, even though it was a low-risk population, HIV negative men, there were actually some seroconversions in that. So it really can't be given every 12. So let's think about the 8 versus 4. Well, the 2 injectable cabotegravir rilpivirine studies, the FLAIR study was, I remember it because you have a FLAIR for new things, was the naive study, and the inclusion criteria were naive. A K103 was fine, actually, because it's rilpivirine as the agent, and that works perfectly well against a K103, and it's a second generation NNRTI. And then participants had to be suppressed on dolutegravir baclofen 3TC for 20 weeks. Then there was an oral lead-in of CAB rilpivirine orally, and then cabotegravir 600 milligrams, rilpivirine 900 milligrams as a loading dose, followed by maintenance of 400 and 600 every 4 weeks. The ATLAS study similarly required virologic suppression prior to entry. These were patients who were experienced, so experienced ATLAS MAP, and had no virologic failure in the past, was suppressed at least for 6 months on their prior regimen, no INSTI or NNRTI mutations except for K103N, which was fine. Then again, an oral lead-in, and then the initiation dose and the maintenance dose. I will remind you in the FLAIR study that there was 121 participants who were able to go to direct to inject. So your patient does fit the inclusion criteria of the ATLAS study, even with the K103N. So how would you give the shots now? 1 every 4 weeks, 2 every 8 weeks, still every 4 weeks for a while, then I'd be comfortable switching to 8 weeks. Or 4, can we discuss cabotegravir resistance seen at 8 weeks to make sure we're comfortable? So still 32% would go 4 weeks for a while, then 8 weeks, but we want to discuss cabotegravir resistance. So let's do that now. So there are really 3 major studies that have shown us what's going on with cabotegravir resistance. The FLAIR that we talked about, ATLAS, but also ATLAS 2M, and that is the one where participants went from every 4 weeks to every 8 weeks. And then HPTN 083 has relevance here because it was cabotegravir given every 8 weeks for prevention, but the resistance patterns will help us understand what could happen in treatment. This is the data from the FLAIR at 124 weeks. And we have data from IAS at 124 weeks and we have data to 96 weeks in Lancet. And really, there's a maintenance of virologic suppression, but it's 80% by 124 weeks. And there were some that discontinued with adverse effects, about 14.8%. And there were 4 failures that occurred between 96 and 1 additional, so 5 that occurred between 96 and 124 weeks. And these were the 5 failures shown here. And you can see that there was failure with the development of INSTI resistance. I'm sorry. So you can see that there was some development of INSTI resistance, G140, GQ148, GQ148 again, and an N155, N263K. So there was development of resistance in 4 out of the 5 failures in the integrase gene. And then if we look to Atlas, we have the 96-week data from HIV Glasgow last year, and there was non-inferiority of the cabotegravir rilpivirine every 4 weeks to continuing 3-drug ARVs. And there were 3 failures in this every 4-week study. And those 3 failures added to our list of the 5 failures that we had from FLAIR, there was a development in 1 of an INSTI mutation, N155. Actually, 2 of those 3 had baseline rilpivirine RAMs on viral genotype. And then here is the Atlas 2M study. This is cabotegravir and rilpivirine every 8 weeks after the 4-week phase. So from the 4-week phase, continuing out after 96 weeks, 100 weeks to 8 weeks, giving it every 8 weeks. And here are the results from Croy and the 96 weeks data. This was the 48-week in the Lancet. And you can see that there were virologic failures, but in the Q8-week arm, there was actually 8 additional failures out of the, 9 additional virologic failures from the 2 that were seen in the Q4-week arm. And so adding in these 9 additional virologic failures in our table, we can see that at that 8-week, we did get significantly more failures, and there was development in 5 out of 9 of INSTI mutations. So this leads me to the next question, given that what we've just talked about is, what do you think the ranking is for genetic barrier to resistance for the INSTIs, lowest to highest? Is it elvitegravir, then riltegravir, then cabotegravir, then dolutegravir? Or is it riltegravir at the lowest genetic, then elvitegravir, then cabotegravir, then dolutegravir? Or do you kind of group them into riltegravir, elvitegravir, and then cab, bic, dolutegravir? Or do you think that cab has a higher genetic barrier resistance than bic and dolutegravir? Or I don't like this 8-week burst of resistance in the treatment trials. Please vote. So I do think that most people said either 1 or 2 if you add those up together. And I think it is hard to tell between them. I think elvitegravir probably has a lower genetic barrier to resistance from the initial treatment trials. But I agree that cabotegravir has a lower genetic barrier to resistance than bic dolutegravir, because in the trials themselves, bic and dolutegravir rarely had the emergence of resistance. It was really in case reports or in at least in the case of dolutegravir with Viking, where really had been used on a very difficult background where there was a lot of resistance. So a cabotegravir does have seemingly a lower genetic barrier to resistance than those 2 others. And this is the HPTN-083 study that also showed us some of this. This was the 2, of course, cabotegravir PrEP trials, but one was in men who had sex with men and transgender women, which was 083, and 084 was in cisgender women. but we got the results of the resistance genotyping for the 16 failures in HBTN 083. And in that study, this was, of course, the design was either IM cabotegravir every 8 weeks versus daily TDF-FTC. And the design of that study, or the results of that study as published in the Lancet, you can see that there were 16 failures, and of those 16, 5 developed virologic resistance, the development of virologic resistance with INSTI mutations. And the INSTI mutations are shown here on the right, but quite a bit of development, at least in those 5 out of the 16 failures. And it really didn't seem to matter. One was undetected HIV at baseline, one was during the oral, 2 were oral during the oral lead-in, and 2 were actually despite on-time injections. So the 8 weeks does seem to give us a little less leeway in terms of the development of resistance. That's both in the treatment trials and in the prevention trials. So now this is our final table put together, that HBTN 083 at 8 weeks and Atlas at 8 weeks had more resistance develop, at least in the slower way that it developed with the giving it every 4 weeks in FLAIR and Atlas. So you go over all this data with the patient, you discuss giving the injection every 4 weeks with some hesitation to give every 8 weeks. And he says, okay, but tell me, since I really want to eventually get the shot every 8 weeks, any risk factors more associated with all this resistance you're trying to scare me about? So that is the question. What are the risk factors for the development of cabotegravir resistance in the combined phase 3 treatment trials? Was it 1, being late for injections? Was it 2, proviral rilpivirine resistance mutations? Is it 3, HIV clade B? Is it 4, HIV clade A16? Or is it 5, having a body mass index of greater than 30? Or is it answers 1, 2, and 5, being late, proviral resistance, and body mass index, or 2, 4, and 5, resistance, A1, and body mass index greater than 30? So actually, the majority of you said 1, 2, and 5, which was being late for injections and proviral resistance mutations and having a high BMI. It's actually 2, 4, and 5, interestingly, because we saw that at least in Atlas 2M and in HBTN 083, even being on time for injections every 8 weeks, there was still emergence of resistance. And so where do we get this conclusion? This was a nice study that was just published a couple of months ago in AIDS that looked at the FLAIR, Atlas, and Atlas 2M studies at week 48 and explored predictors of developing HIV virologic failure to long-acting cabotegravir and rilpivirine. It was a multivariable analysis, and really what it showed us is that having a rilpivirine RAM, and those were actually on proviral, and they had at least 2, having HIV subtype A6A1, and or which is not the dominant clade found in the United States, which is B, and or a BMI of at least 30 was associated with increased virologic failure. So these really, you know, it is rare to develop it, but these are the risk factors. So your patient's BMI is 24. The decision made is to start every 4 weeks with reevaluation as more data evolves when everyone feels comfortable going to every 8 weeks. And he agrees, but he does say that he would like to go to the 8 weeks. And I think it's something that, of course, can be tried. And these are not high numbers, but it's important to remember some of our risk factors. So there's no doubt that we were waiting for these injectable antiretrovirals in some cases to try to use in patients who have challenges with taking daily ART. One problem is we do not have a good way to know that and know how to use them, because they were really studied in the way that I just described in patients who had longstanding virologic suppression on oral therapy. And so it's hard to know what to do with a patient like this. This is a 39-year-old man with HIV. This is my patient who I actually met in an Uber, and he was diagnosed with acute HIV in 2009 at full testing in our municipal STD clinic. His viral load was 500,000, his CD4 was 491. He had an acute retroviral syndrome when he was diagnosed. He was started on TDF-FTC, atazanavir, ritonavir, but never suppressed. He fell out of care and then moved to Florida when he was put on a single pill combination, elbaptegravir, TDF-FTC in 2014. He moved back to San Francisco in 2015. I met him in 2016, but he was having difficulties with adherence due to methamphetamine. On 10/22/2016, he did have a viral load of 12,000, CD4 of 153, and his genotype showed an M184V and an N155 mutation in the INSTI. He had been on elbaptegravir. He was put on darunavir, TDF-FTC, and then the single pill combination when it came out, but he really couldn't take oral ART. He then went back to Florida, couldn't find care that he felt was appropriate for him. He came back to this provider in 2021. Now we have a CD4 count of 18 and a viral load of over 500,000. He states he cannot take oral meds. He just can't remember. He uses methamphetamine. He feels it's very stigmatizing, and he just cannot bring himself to take an oral medication. So he still has the N155H, the M184V. We worked him up for a number of OIs because he had such a low T cell count, and we're really at the end of our rope. So would you put this patient on long-acting cabotegravir rilpivirine? Number one, yes, perfect candidate, high viral load, low CD4, 1 INSTI mutation, long history of non-adherence. Number two, are you crazy? Number three, no, ibalizumab and maybe something else. 4, nuance is the key to decision making. The patient has no other options. He won't take oral. He's young and he is gravely at risk with the CD4 count of 18. Okay, so, I think like me, you recognize that we don't have options. And this is a patient who he is saying he will not take oral medications, and coming in every 2 weeks for an IV medication, ibalizumab, without anything else, because he would have to take an oral, isn't possible. And so we are going to do it. And we did it. And so we started him actually just on June 8th, 2021 on a loading dose of intramuscular CAB and intramuscular rilpivirine. We came in, this is a true story, came in for a second dose on July 16th. He's been extremely careful about coming in, and we drew his pre-second dose viral load and gave his dose that day. So what do you think the viral load was before the second dose? We started with an exact viral load of 516,258. Was it 492,000? Was it 49,000? Was it 4,900? Was it 49, or was it undetectable, less than 30? Okay, so most of you said 46%. Some, just a few thought we didn't get anywhere. And then 10% were sanguine enough to think that he became undetectable. So that is actually what happened. He did become undetectable. His HIV viral load was 30 after the first loading dose. He's now on his 6th dose of IM cabotegravir rilpivirine. Actually, he just got it yesterday. We've had 3 viral loads less than 30. CD4 count is up. He called his mother from clinic on the day of the first viral load. He hugged me. His fatigue is much improved. He's back to Uber. This is a don't try at home case, but this is a true case. So we do have a pilot program for long-acting ART for poorly adherent patients at Ward 86 only when there is no other option. Reminder that the inclusion criteria showed virologic suppression of at least 16 weeks on the oral regimen first, no history of virologic failure, only K103N is allowed no INSTI mutations and oral cabotegravir for 28 days as the lead-in. We have allowed occasionally, and we have about 4 patients who fit this criteria now, does not need to be virologically suppressed or take orals before, will go direct to inject. We don't allow rilpivirine mutations, but we will allow 1 INSTI mutation that's non-defining of cabotegravir. And we require strict demonstration of being able to come to clinic prior to starting this. And we review these patients and follow them very closely biweekly. And this patient, at least so far, is doing very well. I'll end with just a few discussion points on medications that we have already been discussed in the investigational talk by Dr. Benson, but lenacapavir is really this first of its kind novel HIV capsid inhibitor. And first of its kind that it really helps with essentially after you've already gone through virus production and are assembling the capsid. And we have data from CROI 2021 in a phase 2-3 study, because we're really looking at treatment experienced patients here in heavily ART experienced people with HIV. This is the Capella trial. And remember the design of this trial, this really was very multi-drug resistant individuals. And because they had only essentially the option of having, they had actually less than 2 ARV remaining. And then they were randomized to taking oral lenacapavir just as a loading dose on days 1, 2, and 8, and then randomized to staying on that optimized background regimen and getting subcutaneous lenacapavir every 6 months. So this is the 26-week data that is shown here, that you can see that there was actually not in the optimized background regimen, there was not good virologic suppression rates, but in the left side, you can see that we did achieve virologic suppression in this small study, less than 50, less than 200 of 81 and 89%. And of course, what mattered was having at least 1 active agent in the background regimen. Having 1 active agent was associated with 86% suppression, 2 was 81% suppression, and 0, having nothing in the background was 67% suppression, very small patient. And 2 out of 72 of the patients, as Dr. Benson discussed, had emergent capsid mutations conferring high-level lenacapavir resistance, but both did resuppress, but M66I substantially impairs viral replication. So, and then the final drug to talk about, which we've already discussed this morning, so I'll just remind you of what it is. It's a NRTTI, a nucleoside reverse transcriptase translocation inhibitor. It's really also the first in its class. It's very high potency, half-life up to 128 hours. Once per year dosing is feasible. And Connie showed you that data from this morning about the implant and how it will can be given once a week and also once a month. And on March 15th, Gilead and Merck announced an agreement to jointly develop and commercialize long-acting combination of lenacapavir and islatravir. They just announced, their collaboration in March, but just last week announced that the first treatment trial that will launch will be with lenacapavir once a week and islatravir once a week. So it will be a once-weekly regimen, 2 drugs. And so we will, that's exciting, and we'll see how that is. And I will end there and take any comments.
Thanks very much, Monica. Great series of cases to mull through, and kind of good example and demonstration about why there's still a lot of thought involved in what we do every day. Number of questions here related to the logistics of injectables. Any likelihood people are going to be able to get that part of it reimbursed and access along those lines?
Yes, so we also could not get it reimbursed bizarrely on private insurance. We do not have patients at Ward 86 in our clinic on private insurance. We just have Medi-Cal and Medicare. And it isn't Medicare. It's very hard to get on Medicare. And so we literally can only get it on Medicaid, which is Medi-Cal in the state of California. And it's specifically Part D. So it's not, I mean, it's not on ADAP yet. This is, something that just started in May. This is when it was available, and we have about 14 patients on it now, but I completely understand what people are, several comments that it's hard to get. And I will say that if Doug McCormick, if you happen to be in San Francisco, we are happy to share how we can get it on insurance. But again, it has to be public insurance at the moment.
What about the higher maintenance dose? Did you use that or the standard maintenance dose?
So used the loading dose 600, 900 for the first dose, and then went to the 400, 600 as the maintenance dose every 4 weeks.
And what about the M50 mutation? Any issues with INSTI activity?
I'm not able to comment on that, not to my knowledge. It certainly didn't emerge with the cabotegravir. What we likely are not going to use this in patients with INSTI resistance regularly. Again, I'm telling you a pretty rare thing that we did in a patient that I thought we had no options for, who had an N155. But what was significant for us is if you look at the cabotegravir emergent resistance mutations, usually people did not break through with it one N155. It was usually multiple mutations. So we were hoping that we'd have activity, and at least, fingers crossed for the last 6 months we have.
Good. Okay. How about oral lead-ins for the patient that you started?
So we did not do oral lead-ins. And in fact, in a poorly adherent patient population, if you're going to do an oral lead-in, I wouldn't use cabotegravir or rilpivirine. And that was a very conscious decision because they're 2 separate pills. And also the rilpivirine actually does have a low genetic barrier to resistance. The advantage of using injectables in a poorly adherent patient population is when you're giving the injectable. And so if we've chosen to go direct to inject in these rare patients, and even in our patients who had pill fatigue and fit the inclusion criteria of the studies, but we have abandoned the oral lead-in.
Great. Okay. So I think we've gone through the questions. We're just about 2 minutes ahead, but that's good. And why don't I turn it back over to you so you can introduce Roger?